And what I will tell you is whenever we operate on organ donors, before we actually start the procedure, we take a moment of silence, what we call a moment of honor, and just reflect on the donor's life and essentially thank them for the gifts that they're providing to recipients. And there's an opportunity for families to write what we call a family statement before we begin. And this is just prior to the moment of honor, moment of silence. The family writes a statement, and one of our coordinators will read to the entire operating room team. So the surgeons, the nurses, the scrub techs, any other members of the team who's in the operating room. Sometimes it's 2 sentences, sometimes it's a couple pages. It's poetry sometimes it's song lyrics. It's a very moving component of the organ donation experience. And this particular donor was the exact same age as my son, who was a kid at that time. And listening to the statement that his mother had written, describing him, it could have just as easily been my son they were describing.
Hello, everyone. Welcome to another show of HUMED. This is a show where we unveil the human side of medicine. I'm incredibly honored and delighted to have Dr. Charles Strom with us. He is a board-certified transplant surgeon and chief of surgical services at New England Donor Services, which is also abbreviated as NEDS. Since he's joined NEDS in January 2020, right around COVID time, as surgical director, Dr. Strom has grown the team into a premier organ surgical recovery group that it is today. Dr. Strom has been instrumental in the successful implementation of normothermic regional perfusion, which I have a feeling we're going to hear about later on today, and ex situ machine perfusion in New England, as well as the overall growth in NEDS organ utilization. Dr. Strom also serves as co-director of the Galen V. Henderson medical student internship at NEDS. So he's not only practicing as a transplant surgeon, but he's also teaching, which completely resonates with me. He is nationally recognized for his expertise in organ recovery, NRP, and organ perfusion, has several national leadership roles, including serving as the medical advisor-elect for the Association of Organ Procurement Organizations and the Executive Committee of the AST Recovery and Preservation Community of Practice. Most importantly, he is a Manchester United fan. His son is an Arsenal fan, and my son is an Arsenal fan and just got back from London. But seriously, I'm incredibly honored and delighted to have you here. And I know very little about transplant surgery, and this is an opportunity for our audience to learn more. And we were connected from my long-term friend and 4-time experienced HUMED guest, David Shapiro, who works with you, I know, as part of your team. So, Charles, welcome to the show.
Thank you for having me. I told Dr. Shapiro that it's very important to me that we get more views than any of his podcasts will receive. So we have to go out of our way to.
It's going to be huge.
And I hate to correct you right off the bat, but I'm a Manchester City fan, not United. So
Manchester City. Okay, good. All good.
I got to make sure I represent.
So it's very.
Thank you for having me.
Yeah, in the U.S. it's okay, but once you get to England, it's very serious stuff.
I think if you were in Manchester, exactly.
So tell us, interested in a story. You know, we at Human Medicine and the journey has been really about storytelling and then exploring that story and really unveiling the human side of medicine. So I know I've been dying to hear your story today.
Well, I know that was my assignment, and I thought a lot about which one to start with, and I will tell you an early experience I had in transplant surgery, especially in organ donation. I was in my first week of fellowship starting. I had just finished my general surgery residency, and I had decided I wanted to go into transplant. So transplant surgery is a 2-year fellowship. Extremely challenging, especially in terms of the hours that you work. You travel all over the country to operate on organ donors and then bring livers back to your recipients at your home institution. We flew up a couple states north of us to operate on a very young donor. I think he was probably not much more than 10. And what I will tell you is whenever we operate on organ donors, before we actually start the procedure, we take a moment of silence, what we call a moment of honor, and just reflect on the donor's life and essentially thank them for the gifts that they're providing to recipients. And there's an opportunity for families to write what we call a family statement before we begin. And this is just prior to the moment of honor, moment of silence. The family writes a statement, and one of our coordinators will read to the entire operating room team. So the surgeons, the nurses, the scrub techs, any other members of the team who's in the operating room. Sometimes it's 2 sentences, sometimes it's a couple pages. It's poetry sometimes it's song lyrics. It's a very moving component of the organ donation experience. And this particular donor was the exact same age as my son, who was a kid at that time. And listening to the statement that his mother had written, describing him, it could have just as easily been my son they were describing. He was an avid soccer player. Personality-wise, he was very similar to my son in school. And I'm listening to this, and it's quite literally my first week of fellowship. So this is all, I'm with 2 different attendings. I really want to make a good impression. And they're telling the story. And I'm not a particularly emotional person, but of course my eyes start to well up listening to this because, of course, it's about their loved one, the parent, the son of these 2 parents who had written the statement. But all I can picture is my son. And I think I hadn't slept in like 36 hours because that's how transplant fellowship is. And my eyes start to well up. And, as I said, I just want to make a good impression. And, I think surgeons are oftentimes celebrated for being somewhat stoic and not letting emotions get the best of them. And all I'm thinking is what's going to happen if tears start actually coming down and, essentially over my mask and contaminate the surgical field. And I'm just thinking that, I'm going to be out of this fellowship before it's even started. Thankfully, that didn't happen. The procedure actually went very well. I think this particular boy saved 6 different lives that day with the different organs he donated. Wow. I did find out and follow up a couple weeks later that his mother had said that it was the only rewarding thing that came out of this untimely death was the fact that he saved so many lives and contributed in the way he did. So that's it's always moving when you hear that. And when you recognize that, even as a very small piece of that puzzle, you've had the opportunity to provide life to others and to honor the wishes of someone who's passing. That really influenced me strongly early on. And really, interestingly, I was starting fellowship to be a transplant surgeon, but I think that was one of the first experiences that really started to push me more in the direction of donation than actually doing the transplants. And that evolved and developed over a number of years thereafter. But it was very profound and a very, very strong effect on me early on.
Well, it's beautiful. Do you get to meet the families of the donors? Do you actually get to personally meet them before the surgery, or is there a procedure? How does that work?
Right. That's a great question. The surgeons typically don't. There's no rule against it. I always thought it might not be what a family wants to see the person who's about to operate on their loved one who's passed. I have met a couple families a couple times at their request, and I'm certainly happy to do so. I'll tell you a story. We maybe 2 years ago, I went to a hospital in Boston to operate an organ donor, and it was a middle-aged guy with a couple of younger kids, and we found out that before starting, the family wanted to speak to me. And I certainly was happy to do it, although it's a rarity that I do. So I went out and met this family. And, I have so little experience actually talking to the families before the procedure. And I admittedly, I didn't even know what to say. So I walked out and the first thing I said was, I'm sorry for your loss, but thank you so much for the gifts that you're giving. And they had a lot of questions that were actually about the procedure. Some of the gory details about the surgery itself, which I was really surprised by. I wouldn't have thought a family had wanted to hear about it, but I think they wanted the security of knowing what was happening and to have some degree of control there. So I did that. And actually they asked me if they could take a picture with me at the end of that before the procedure. And I immediately said I would be happy to, as long as you don't put it on social media, please. but yeah, with the kids' arms were around me, and
Oh.
the wife was there as well. Now, it was an interesting experience. I think, at New England Donor Services, where I work, we have a very sizable staff whose primary job is to work with families and engage with them, and they do an unbelievable job that I certainly could never do, just because of the sadness I think it would evoke. But they are with the family from the moment they decide to move ahead with organ donation until the moment that their loved one is taken to the operating room. And then thereafter as well, we have an aftercare department here who follows with the family for very prolonged periods of time after the donation, updating them on recipients, how many lives were saved as a result of their loved one's gift. A couple of details, mostly the age and gender of the recipients. We don't give more details than that, but actually we can facilitate communications between the donor family and the recipients later on as well. And a number of donor families have said that that's been one of the most rewarding things for them as well, to actually meet the recipients of their loved ones' organs. And, you hear stories about a mother who hears her child's beating heart inside of a recipient with a stethoscope. And again, I say it all the time. I think oftentimes it's one of the only good things that comes out of it, the tragedy of losing a loved one. So it's a really meaningful experience for a lot of these families, and it's a job that our team at NEDS does really well, and certainly something I'm proud to be a part of.
So you had said that one donor, and again, I don't mean I have a sense of this, but I'm very, very naive to your world. I'm a pediatric ER physician, so we actually end up saving lives, or there are times where we believe the child may likely be brain dead, but we don't know.
Yep.
So we do whatever we can to keep them alive in the pediatric ER to get to the ICU, and then perhaps you might take over. So what you had said that this particular child that you welled up in the family statement, which I want to get back to, you said that this one donor actually saved multiple lives. Can you explain a little bit of that, and like what organs you actually procure? Because that's very interesting to me.
So it's a great question. So when we talk about organ donation, a younger healthy donor can save up to 8 lives in terms of the organs they donate. They can donate their heart, their lungs, their liver. The liver can actually be split into 2 different pieces. The liver, part of the biology of it is that it can actually regenerate on its own. So a liver can actually be split and put into 2 different recipients, which is uncommon, but it happens. They can also donate their pancreas, their 2 kidneys separately, as well as their small intestine, which is very uncommon, but it happens as well. So this particular child, there were 6 lives saved in terms of the organs he donated. In terms of what my training is in abdominal transplant surgery, so the organs I recover are liver and kidneys and pancreas. Typically to donate heart and lungs, those are usually thoracic teams. So the team that is receiving the heart for their recipient back home, they'll often fly out or drive to the donor hospital, operate on the heart. Likewise, the lungs, oftentimes the recipient team will come and recover the lungs and bring them back to their home base as well.
So take the viewers through an experience. So a 10-year-old child has an event, and I'm assuming it can be a series of events that lead to brain death, which could be a drowning, it could be a motor vehicle accident, some sort of event that leads to the definition, I believe, of brain death, and then but the organs remain alive. Can you explain that?
Yeah, great question. And so
to get to where you come into play.
Yeah. Well, so let me answer that, but I also, just so people understand, there's essentially 2 avenues to donation. One is when someone has been declared brain dead. And the other, which we can certainly get to, is what we call DCD, or donation after cardiac death. And those are in patients who are, for lack of a better term, close to brain dead, but they have some degree of usually brainstem function. So they still have like a respiratory drive, or they're still blinking, and any number of things like that. But these are people for whom the primary team taking care of them in the ICU have had extensive conversations with the family and have basically said this is a non-recoverable injury. They will not recover. And traditionally, these are patients who in the ICU have their ventilator withdrawn, their medication stopped, and are just given comfort medications and essentially allowed to die naturally. And that happens hundreds of times a day in ICUs all over the country. There is an avenue for them to donate if they're registered donors or if their families want to move forward with donation, and we can speak about that for hours. And that's actually my greatest interest professionally, is in maximizing the number of lives saved from that type of donor. But to get back to your prior question, in the case of a brain dead donor, a person is typically brought into a hospital, usually through an emergency room. As you said, it can be from a drowning, a motor vehicle accident, a stroke, a heart attack, what have you. And oftentimes they're usually in the hospital for a couple of days as the ICU team takes care of them. We I work at NEDS, which is an OPO, organ procurement organization. I can talk about that a little more. We typically don't get involved with anything. We don't even typically know about these patients until they're either declared dead or the hospital team has essentially established that there is minimal likelihood of recovery, at which time we're contacted by the hospital and asked to come and evaluate the patient to see if they would even be a possible donor. Really only about 1% of deaths in the US are even fit within the criteria that would allow for organ donation in the first place. So it's very rare. So when we do get contacted, a coordinator, a member of our staff will present to the hospital, discuss the patient with the care team who's taking care of the patient, review all of the records, the chart, the labs, what have you. And if it seems like organ donation would be feasible, we then approach the family to see if that's something they'd be interested in moving forward with. If the person is a registered donor, we'll approach the family, let them know that their loved one is a registered donor. More often than not, they already know that, but sometimes they don't. So in a case like, as I described earlier, this child had been in the hospital for a few days, had eventually been declared brain dead by the hospital team. OPOs have no involvement in the declaration of death whatsoever. All of the actual care of the patient is provided by the hospital. And this patient had fit all of the criteria for brain death, 2 different clinical exams performed by different physicians at the hospital, an apnea test. Sometimes patients get imaging studies to confirm there's no blood flow to the brain, which
and when you mean by an apnea test, if you don't know what that word is, that means that they're
right. So
they can't breathe on their own.
Right. And there are a number of lab criteria that after you stop their ventilator for a number of minutes, they demonstrate that they cannot breathe on their own. That's exactly right. So after all is said and done, once a patient is declared brain dead, from a legal standpoint, they've died. Having said that, if they're still on a ventilator, the machine is doing the work of breathing for them. And so the heart is still beating. The tissues throughout the rest of the body are getting blood flow. They're getting perfused and continue to function, even though the brain has died. And so the person has died. In those cases, after they have died, they can go to the operating room and the organ donation procedure happens.
So thank you for explaining all of that. I'm curious, you do lots of things. You teach, you procure organs. What's hard about your job? You've been doing this now for many years, and you are now experienced at this. You have developed procedures to improve perfusion in the abdominal cavity, which I want to get to, by the way. But what's hard about your job? What do you struggle with on a day-to-day or week-to-week? What is Dr. Strom thinking about that's hard for you? Is it getting up at night? Is it
Yeah,
crazy
yeah.
hours in the
It's
morning? You have a family. You're a dad. You have a human life outside of medicine. What is hard for you in your life, either personally or professionally, that you struggle with?
I think it's a lot of hours, um,
Mhm.
and you know we go sometimes in a period of a week where every day you're traveling. We're just outside of Boston, and one day I'm up in Maine, and the next day I'm in Connecticut, and the day after that I'm in Rhode Island. The surgery
Flying? Are
itself,
you flying or driving?
we don't. There are teams that do fly.
Mhm.
Our what we call our service area, which is most of New England, is
Mhm.
essentially small enough that we can drive to just about any donor hospital within about 4 hours, and so there's really no need for me to fly. I'm also deathly afraid of flying, so I'm happy to drive. Um, but yeah, I think the travel and the hours can really take a toll on you,
Mhm. Mhm.
and especially when you have a family and you have kids and
Mhm.
you miss a lot of things. I'll tell you a story. When my son was graduating from elementary school, which is it's not a big event in life, but at the time it
I
feels like it.
disagree. It's a milestone.
Right, right,
It's a milestone, right? It's important.
yeah. So I remember distinctly, he was really excited about the graduation ceremony, and the whole family and grandparents and everyone were going to come. And then about 2 hours beforehand, I got the call that I had to go to wherever and operate an organ donor. I was going to miss it, and that's part of the job. And I understood it, so I really wasn't sure how to address it with him. And I didn't want him to take it personally or whatnot. So I went up to his room. He was getting ready, and I just said, his name is Jack. I said, Jack, I feel terrible, but I'm going to have to miss it. I have to go to work. And he really didn't bat an eyelid. And he just said, no, Dad, you know, saving lives is more important than graduation. And,
Mm.
this is like 11 years old at the time. And so, similarly, my daughter is an avid softball player. And
Mm.
one of my favorite things is going to her softball games. And so I cannot tell you the number of games I've missed at the last minute because something has come up and I've had to go to that. And it takes a toll. And that's not just in organ donation, that's in any field of medicine. I'm sure, people, all of your listeners and viewers have experienced that, but there's an unplanned nature to it,
Mhm.
that can really take a toll on you. The only thing I would say though is that however challenging that is for me or a member of my team, I always try and remind myself that it's 20,000 times harder for the family of the loved one who you're about to operate on. And it's a good way to ground yourself sometimes when you start to get frustrated about how much work you have to do or how much travel there is, to remember that this is still your job. And it's a gift to be able to provide life to others through this process. For the families who are losing loved ones, there's nothing good about that day for
Yeah.
them. So I try
One
to
of the
remind myself of that.
Yeah, one of the surgeons I had on the show, Dr. Greg Albert, he's a neurosurgeon, pediatric neurosurgeon with us here, and he said something very similar, so wise and sage, which is that it's a day-to-day job for him, or potentially even for you, even though yours is stressful as any kind of surgeon might be, being called in to do something emergently. But there's a family on the other end who's having a really difficult time, and it's potentially their worst week of their lives on some level. So you had described to me a bit of a buzz and let's call it controversy
Yeah.
around the transplant world, which I don't know much about. But can you talk a little bit about what sort of controversies there are, whether it's
Yeah.
ethical or moral
Yeah.
or social media stuff? And the reason why I bring this up is that one of my highest viewed videos is I interviewed a mentee of mine who went to Nepal when she was in college and was inspired by a Nepalese physician who was giving out polio vaccines. That's all he did. And he was trying to wipe out polio in this area of Nepal. And really, her story was about being inspired to become a pediatrician, but that video has received so much controversy because of the vaccine stuff and the anti-vaxxers and all of that stuff. So I want to sort of get into and understand what are the controversies that exist in your world publicly.
Yeah. Let me give you an example to start. I'm going to give you a story. I went down to Connecticut. This was a few years ago. Actually to a transplant hospital. The hospital I was going to operate on the organ donor actually had a transplant center. So you would think the staff would be pretty well educated. This was one of these cases I told you about, a DCD, where the donor wasn't, the patient wasn't brain dead. They had an injury from which they were not going to recover. The ICU doctors had multiple days of extensive conversations with the family, who had said, this person's not going to recover. But they were a registered organ donor, and the family was very pro-donation. They really wanted to see something good come out of their loved one's death, and they were very encouraged to know that we would be involved in that we thought we could recover some organs and save some lives as a result. So our organization was contacted. As it usually does, it took a day or two to set everything up. We go down there, and I get to the hospital. I'm usually the last one there. And I walk into the operating room, and a number of members of my staff come and grab me, and they say, we need your help. We need your help. There's a problem. And so usually the problem is that there's a delay in the OR, and the family's upset because they're trying to have some control over what's going on in their lives. And now the OR is telling them that there's going to be a 4-hour delay before we can even do it. And I said, okay, what's the problem? And they said one of the nurses is making some accusations about us. And I said, what are the accusations? And they said, we think you really ought to talk to her. So it turns out this woman is not even involved in the donation case. She's not the circulating nurse in our operating room. She's just a staff member at the hospital. So they bring me to her, and I put my hand out. I say, I'm Dr. Strom. I understood you might have some issues or questions about what we're doing. How can I help you? And this woman looked at me and said, I'm not talking to you. You're a murderer. You're just here to kill someone. You're an organ vulture. What you're doing is wrong. And so I not the first time I've heard something like that. So I kind of took a moment and I said, I'm sorry you think that. How can I talk to you about what we're doing here and maybe help you understand? And this woman had no desire to talk whatsoever. And I actually tried to do a little bit of education with her because I, of course, believe in what we do. And I certainly don't want to see a member of the medical profession be so misled about how organ donation works. So I literally sat with her and talked about how we as an organization hadn't even been involved in this case until the family and the hospital had reached out to us. That this person was not going to recover, that the patient, as well as the patient's family, were very pro-donation. And in fact, if they weren't donating, they were still going to be taken off life support and given comfort medicine and be allowed to die naturally. The fact that we were present was only to allow organ donation to occur and nothing else. She reiterated her comment that I was there to murder an innocent person, and that I didn't know what I was doing, and that she should be calling the police. And I think at that point I said, I'm assuming you don't have any family members who are waiting for organs, do you? Or who are waiting for a transplant? And she said, no, why? And I said, maybe you would feel differently if you had a loved one who was on dialysis or who was dying of liver failure. We at that point, we just kind of recognized we were at an impasse. I actually said to her if she would like to come into the operating room for the procedure, she would be welcome to, so she could see everything we were doing and how above board it was. I actually had wished she could have listened to the family statement which I had talked about earlier, because I thought maybe that would demonstrate to her what we're doing and the importance of it, but she wanted nothing to do with us. So I guess when you ask what some of the controversies and conflict are, that's one of the big ones, is that OPOs, organ procurement organizations like NEDS, where I work, are out to essentially harm someone, and steal their organs or sell their organs or some nonsense like that. That's a challenge. It's a big challenge when you've essentially dedicated your life to saving others and helping others and honoring the wishes of people. I really think organ donation, transplant, is one of the last truly altruistic fields in medicine where you are honoring the wishes of a donor and their family. The donor and their family are not getting anything financially out of it. They're not benefiting. I certainly am not benefiting. We're doing this to help others, and this is dedication to saving lives.
Not only saving lives, but one procurement could, as you said, lead up to 8 lives saved, with people who are on lists who would die anyway from liver failure or kidney failure if they don't receive the organ.
Right.
So, but I want to get, because I'm obviously in the pediatric world. So when I've signed things, I both have a living will, and I think I've done as much as I can, and I've signed what I need to sign for my license as an organ donor. My family knows what my wishes were. God forbid, if I were in an injury, I would hope that some of my organs could save someone else's life if that were to happen. How does it work in the pediatric world? Because you described your case as a 10-year-old. And so 10-year-olds don't have the ability to know, and obviously it's extremely rare when that happens. So how is it different when it is a child versus an adult?
Yeah. And thankfully it's extremely rare. When it's a child, it's at the discretion of the parents or the next of kin, the legal next of kin. It's hard to even think about, the mental and emotional suffering that you're dealing with as a parent or a loved one when a child's dying. But the authorization to move forward with organ donation is entirely based on whether the parents or the next of kin want to do so. There's no, we certainly don't operate on children or really anyone for that matter without the consent of the family, the authorization from the family. When it's an adult and it's a registered donor, that essentially is a living will. That takes precedence over anything. But in children, under 18, it's 100% based on what the next of kin wants to do.
And the organization that you work for, NEDS, I'm assuming part of their work is education. Both do you educate the public? Obviously you need to educate the hospitals in your system?
Yeah, it's a great question, and we have incredibly dedicated staff that does education on multiple different levels. We have a huge hospital development team whose really their primary job is to go to hospitals throughout our region has something like 200 hospitals that are capable of facilitating organ donation. We have staff that go to every single one of them and talk to the ICU teams, talk to the emergency room teams, talk to the operating rooms, educate them on what are the kind of clinical criteria that, when met, they should reach out to us. And likewise, we do a lot of education of the public. We have exceptional people who go to the RMV, go to driving schools, go anywhere that would facilitate the opportunity to teach people about the organ donation process and the importance of registering to be a donor. It's in this day and age, and you started to touch on it earlier, what are the challenges, what are the conflicts that exist in organ donation right now? One of the biggest ones is misinformation about organ donation and about OPOs and how a couple of really poorly placed news media reports really influenced a significant amount of the public. Last year was the first year in maybe decades where the donation rate actually decreased. Excuse me, the registration rate decreased, where people were actually removing themselves from the donor registries because of misinformation they had heard about, oftentimes on social media, but even in a couple of reputable news sources that grossly grossly provided significant misinformation about organ donation cases and the organ donation system as a whole. So it's a challenge. And so, OPOs, I think the biggest thing we can do is get out there, educate, really just tell the truth and let people know about not just the importance of organ donation, but the importance of making decisions, before death, registering so that, and having discussions with your family so that your family knows what your wishes are, should, God forbid, something happen to you.
Yeah, and also for hospital systems to be aware of what the criteria are.
Yeah.
So to give an opportunity if someone wants to do that.
Right.
So what can you explain to me the finances and the financial healthcare system in the United States is fragmented at best, and at some point, I think somewhat dysfunctional compared to other systems in the world. But also, there's some amazing things in terms of innovation, and I'm very optimistic about our healthcare system, although we know that there are challenges.
Yeah.
Can you explain a little bit about how the finances work of who is paying for what to make this process happen, on maybe on a high level?
I'm probably the worst person to discuss that. It's not my area. The most important thing to know is that the organ donors and their families don't pay a penny for anything. I think
I had a feeling, yeah.
Probably is the single most important thing. There's no financial hardship that occurs as a result of donating an organ. The finances really, and again, I will tell you that I'm by no means an expert on this topic, but typically are split, depending on which organ, between Medicare and then the recipient's insurance companies. Kind of down the line, there's multiple steps involved, but in the end, the bulk of the cost for kidneys is covered by Medicare, and for other organs, typically insurance companies for the recipient's insurance.
Yeah, it just seems to me from what you've described, not in terms of there are so many different steps it takes to declare someone brain dead and be applicable to be a donor. And then we haven't even talked about it, nor do we have time, but my understanding is that there are also procedures and steps around recipients and who's available to be a recipient, and where you are on a list to actually receive organs as a recipient. So there are rules set up, and my understanding is the reason why there are very strict rules set up for both the procurement and on the receivership standpoint, receiving organs is to create the highest level of ethical standard possible to be equitable amongst all people, whether they want to give or whether they want to receive. Is that true?
I think that's the perfect way to describe it. Every step of the process is incredibly tightly regulated, incredibly, and on the donor side very much so, and on the recipient side as well. There's over 100,000 people, waiting for, we're on the recipient lists right now. The vast majority of them are waiting for kidneys, but all the other organs we've mentioned as well. It's essentially a federally created list of who stands where in terms of allocation for them, and they're based on different criteria. For kidneys, the primary criterion is how long you've been waiting, whether how long you've been on dialysis or how long you've been waiting for a kidney transplant. The other organs are a little bit more based on how sick the recipient is. So you could go on the liver list today, and if you're essentially the sickest person in America based on your liver failure, you're at the top of the liver list for every organ that might be transplantable for you. For every liver, your center is getting usually the offer first, and that's done incredibly objectively, and the transplant centers and the OPOs have really no control over where someone sits on the list. It's like I said, it's created by federal organizations. There's federal oversight, and we don't control that at all.
Yeah. Well, there's so many different things I have a sense. And again, your world is so different than mine, which is fascinating, right? We both went to medical school. We both completed 4 years of medical school in the United States, and yet your world is completely different than mine. So what can you tell me a little bit about, because you're a teacher, you're operating, you're obviously a father and a family man. What in terms of innovation, I understand, and I'm gleaming that you're doing some really cool things to actually improve the success rate of taking an organ from a donor and giving it to the recipient. Can you at a high level explain to some of the audience what you're doing in terms of innovation?
Yeah, it's such a good question. I would tell you that probably in the last few decades, the single greatest innovation, and from a 30,000-foot view, is in organ perfusion. And what perfusion basically is it is creating flow through the blood vessels of donated organs, either of blood or a preservative solution, either after the organs are out of the body or before the organs have even been recovered from the donor. The perfusion is done in such a way as to markedly improve the quality of those organs, such that more organs can be donated, and those organs that are donated function considerably better in the recipients. So one of the areas that I've been most involved in, and is one of my greatest areas of clinical interest, and you mentioned it already, is called NRP, or normothermic regional perfusion. And this goes back a little bit to what we had talked about earlier about the two different types of donation: brain dead donation, donation after brain death, and donation after cardiac death. And from a very kind of high level overview, DCD donors who are not brain dead, those organs that they donate have forever been slightly more marginal in quality. And the reason for that is when you take a patient and the family makes the decision in conjunction with the hospital care team to remove life support and give them comfort medicine, they're allowed to die naturally. You don't do anything. The hospital doesn't do anything. Certainly the OPO doesn't do anything to hasten their death. You allow them to die as they normally would. And typically, if they die within 2 hours of the removal of life support, they can move forward with organ donation. You have to imagine that there's a time period over that up to 2 hours where the blood pressure goes from normal to zero, where the oxygen saturation goes from 100% to zero. And all of those organs in that patient take a real ischemic hit. The ischemia of that time period affects them markedly.
And for those of you who don't know, ischemia is lack of oxygen.
Low oxygen to the
tissue, at the tissue level and cellular level.
Right. That's right. So it is so bad, in fact, that traditionally hearts could not be recovered. For quite a long period of time, hearts couldn't be recovered, certainly at the rate that they are in brain dead donors. And likewise, livers for a long time, there were very strict criteria around which livers could actually be used in DCD donors, so that someone who was a little bit older, 60-year-old or 65 or older, transplant centers wouldn't pursue those livers because the hit they took in that time period after extubation, after removal of life support, really had a profoundly deleterious effect. What NRP is, or normothermic regional perfusion, is after they die, after their heart stops, we wait 5 more minutes to ensure that the heart doesn't restart. That's very intentional because there's never been a documented case of a heart restarting on its own more than 4 minutes and 20 seconds after it stops. So if you wait 5 minutes after a heart stops, there's never been a documented case of a heart restarting on its own. So we wait 5 minutes before moving forward with the procedure just to ensure that the person is absolutely dead. They've absolutely passed. And what we now do, and it's different from how DCDs used to be performed, DCD donors, rather than rushing in and immediately flushing cold preservative solution through the blood vessels and filling the abdomen and chest with ice. We actually put the abdomen now on cardiopulmonary bypass, just like very similar to if a patient's having heart surgery, having a cabbage or a valve replaced, they get put on bypass. So the heart can essentially stop, but the bypass machine does all of the work of circulation, perfusion, and oxygenation throughout the body. We're doing that now after the person has died, for upwards of an hour or two. And what we have found is that the quality of their organs increases by like an order of magnitude.
Wow. And you don't pack with ice because you use the word normothermic, which means
it's exactly right. So obviously the body is made to function at a certain temperature, 98.6.
Yeah.
You pack with ice to basically arrest metabolism as much as possible, so that the organs can essentially stay viable longer outside of the body. But in NRP, you keep them at their body temperature, and you pump blood throughout the abdomen to the liver, to the kidneys, to the pancreas for an hour or two. And you do that before you take the organs out. Mm-hmm. What we have found, and our center, our organization has done more NRP than anyone in the country has, the number of organs, the number of gifts that can be given as a result of this procedure has increased more than you could possibly imagine, especially in older donors. That's where we've seen it more than anything. So in the 60, 65-year-old plus age group, those donors, when they were DCD, you would have been lucky if maybe one of their kidneys had been used back in the past. Now we very, very regularly are seeing their liver and both kidneys transplanted, which is the most rewarding aspect of the donation process itself. Being able to honor the wishes of that person, of the patient, honor the wishes of the family, and see those lives saved as a result, it's been one of the most profound, I think, accomplishments in the organ donation space in decades. And it's really, it's a procedure. It's just picking up steam. We do an unbelievable amount of it in New England, and there are a number of other parts of the country where you're seeing it happen a lot, but it's really just the beginning. I would wager that in 5 to 10 years, the whole country, everyone will be doing it regularly. And the number of lives saved as a result will be dramatic.
Well, you have inspired me today, and seriously, I'm incredibly honored to have you on the show, and I've learned a lot, and I know my listeners will. What is one thing you would share with the public around donation, and what is one thing you would share, because we have a number of physicians who listen to the show, what's one thing you would share to our physician colleagues that's important to know about the world you live in?
I think the first thing actually applies to both groups, and that is that the United States has the best, most successful organ donation system in the world. Last year, I think there were more than 16,000 organ donors that saved more than 40,000 lives in terms of the transplants as a result. It's incredibly safe. It's incredibly well regulated. The importance of registering to be an organ donor cannot be overstated. There's every opportunity to make a difference after you've passed. And there need be no concern whatsoever about mistreatment by hospitals or OPOs if you're an organ donor. I just can't stress it enough. It is the safest system. It is the best donation system and transplant system in the world. I would say that applies to both the public and to physicians. I think to physicians directly, I would just say that OPOs, who, as I said, are the nonprofits who manage the allocation, do not take on any of the patient care responsibilities that we as physicians, I shouldn't say we, I should say you as physicians perform. We are not involved in the management of living patients. We are not involved in their declaration of death. You can feel very, very safe that all of the work we do is only done after the hospital team has managed the patient up until their time of death. And any concerns that that OPOs or members of donation organizations are trying to usurp any of the control of the physicians need not occur.
And you didn't mention this, but you alluded to it, that is there a need for us to be doing more organ donation in the country? Are there people on lists that don't get organs, even with the tremendous number that you've said happen? There's a need to do more. Is that correct?
I've been careful not to give too many statistics in this discussion, but what I would say is there's over 100,000 people waiting for transplants. 13 people die every day on the list without getting a transplant. Every single day, 13 people die.
That's an important statistic to get out there, my friend. It really is.
7 people are added to the list every day as well. Mm-hmm. And if everyone who could donate did, we would save a lot of lives.
Mm. Well, thank you again. Honored to have you on the show. Look forward to having you back at some point. I think that what you're doing with your innovation and really ultimately what's happening here is you're doing what we said when we all went to medical school, which is you're trying to improve the healthcare of others and actually literally saving lives on so many different levels. So, and I was really moved by what you said around the family statement. That is incredibly meaningful to me as part of your process that I doubt anyone knows that is not living in your world knows that happens in terms of a moment of silence. I hope you have a great day. Listeners on HUMED, please continue to support us. Subscribe on YouTube, Spotify, Apple Podcasts, wherever you get your podcast information. Thank you so much. At the time of this taping, we have almost 70,000 YouTube subscribers, 2 million views every month on Instagram, and we continue to grow. And because we have amazing people like Dr. Strom on the show, and we continue to be on this journey of unveiling the human side of medicine. I hope you all have a great day.
Thanks for listening to HUMED with David Spiro, MD. If you like this episode, make sure you're subscribed on Spotify, Apple, or your favorite podcast platform. The video versions are also available on YouTube. Make sure you subscribe and hit the bell there so that you never miss a future episode.